Hello everyone, I'm Dr. Komal, working as a consultant cardiologist at SL Raheja Hospital, Mumbai. Today we are going to talk about resistant hypertension. So, what is hypertension basically? It is like normal blood pressure levels, like day to day life, we hear hypertension, blood pressure. What is it exactly? Normal person, any person with a normal blood pressure, the upper limit of blood pressure should be less than 120 millimeters of mercury, which is called systolic blood pressure. And the diastolic blood pressure, that is lower limit of blood pressure, should be less than 80 millimeters of mercury. So anything above these numbers is called hypertension. So there is again something called pre-hypertension and hypertension actually. So pre-hypertension is blood pressure, upper limit of blood pressure between 120 to 139 millimeters of mercury, and lower limit of blood pressure should be 80 to 89 millimeters of mercury. And beyond 140 millimeters of mercury, it is hypertension. It is designated as hypertension. So why there is so much of emphasis on this hypertension or uncontrolled blood pressure is hypertension contributes to the major cardiovascular comorbidities in general population, like coronary artery disease, myocardial infarction, that is we call commonly as heart attacks, then cerebrovascular accidents, that is stroke, whether it is ischemic stroke or hemorrhagic strokes, then heart failures, peripheral vascular diseases, then something which is called end organ damage, that is kidney dysfunctions, then retinopathies, that is damage to your eyes. So there are numerous effects of the uncontrolled hypertension, which can be life threatening. So it is very important to know your blood pressure levels and control that in time. Then there is increased morbidity and mortality amongst hypertensive individuals than the people who are not having any blood pressure. Death rates are significantly higher, that is 40% higher in patients with patients with hypertension than in non-hypertensive patients. On follow-up, after starting the antihypertensive therapy, there is 36% reduction in general population in rates of stroke and coronary artery disease. The various studies have been performed and they have found this thing. And also, yearly percent risk of cardiovascular events in hypertensive patients after age of 40 is 0.5 to 2.5%. When the blood pressure goes above 115 by 75 millimeters of mercury, each increase in blood pressure by 20 millimeters, 20 by 10 millimeters of mercury doubles the risk of cardiovascular disease. So know the importance of having strict control of the blood pressure levels. Systolic and more than diastolic, systolic blood pressure is more predictor of this cardiovascular risk. Around 60% cases of elderly hypertensive patients are having increased cardiovascular diseases. So now we come to the resistant hypertension and how it is different from uncontrolled hypertension or pseudo resistant hypertension. So resistant hypertension, the patient is labeled as resistant hypertension when there is failure to achieve the blood pressure goal with maximum tolerated dose of any three classes of antihypertensive medications, one of which should be diuretic, or a controlled blood pressure with four or more classes of uh, antihypertensive medications, which excludes newly diagnosed hypertension, uncontrolled hypertension, and of course, pseudo hypertension. What is uncontrolled hypertension? Lack of blood pressure control in patients who are already on treatment, but with inadequate doses of the medications, poor adherence. and patients who are having untreated secondary causes of hypertension. Pseudo resistance is when patient is on adequate treatment, it doesn't have resistant hypertension, but falsely the blood pressure is being recorded as higher blood pressure, which may be because of suboptimal BP measurements like inappropriate cuff or inappropriate settings, surroundings. Then white coat effect, that is patients while at home or in familiar surroundings, blood pressure will be normal. But when patient enters doctor's cabin, then that time patient blood pressure is known to be on higher side, and of course the poor adherence of the treatment. So factors which are contributing to the resistant hypertension, like I said, three or more drugs are required for the control of blood pressure in these patients. The actual prevalence of this group of patient is unknown. But in general population, around 5%, 5% patients in general practice and almost 50% patients in nephrology clinic are found to have this resistant hypertension. There are various factors which are contributing to this resistant hypertension. First is drug induced, like various other drugs which patient might be taking, like NSAIDs, that is various painkillers. Then drug abuse like cocaine, amphetamines, oral contraceptive pills. Then the steroid hormones, adrenal steroid hormones, which nowadays a lot of people take for muscle buildings and all. Then erythropoietin, cyclosporins, excess of alcohol, then volume overloaded state, that is excess of sodium intake, volume retention because of kidney diseases, inadequate uses of diuretics for the hypertension, which patient is already on taking. Then other causes are renal parenchymal diseases, um, then renovascular diseases like renal artery stenosis, which most oftenly goes unnoticed. Then obstructive sleep apnea, which is nowadays seen very commonly in general population. And screening for which, like when patient comes to you, you need to screen patient, ask provocative questions for the to rule out this particular condition, because it is completely treatable and reversible treatment. Then aortic coarctation, then thyroid diseases, intracranial tumors. These are various conditions which contribute to this resistant hypertension. Then pseudo, or we discussed already what is pseudo resistant hypertension. Patient does not have resistant hypertension, but it is falsely labeled as being on treatment, but being having no uncontrolled blood pressure. So how to diagnose this condition? It is not a overnight diagnosis or one point of time diagnosis. Patient needs to be screened periodically to come to the diagnosis, and of course the ambulatory blood pressure measurements. If there is no like adequate information about patients this previous blood pressure records, then these two things are there. A patient needs to like once the patient is diagnosed with hypertension, there should be routine follow-ups with the patient uh, for the assessment of his blood pressure levels and other physical examination to know the signs and symptoms of associated diseases which may be contributing to the increased blood pressure levels. So, routine periodic checkups for fundoscopy to rule out retinopathy, then biochemistry, blood biochemistries for to assess the renal functions, then thyroid functions, complete blood count. All these things are very important. Physical examination is necessary to know, like for heart, lung examination, abdomen, to rule out any other causes contributing to the condition. At times, if we fail to rule out certain causes, then like medical renal disease or The renovascular diseases, USG abdomen will be needed. And then, of course, neurological examination. So all these things are needed. Patient needs to be evaluated carefully at each and every visit to the clinic, so that we know what is happening with patient's blood pressure level. And if the condition exists, we need to treat that in time. So now management. So there are three modalities of treatment. One is non-pharmacological, then pharmacological, and something which is a very new new modality of treatment coming in picture nowadays is surgical management for hypertension. So non-pharmacological treatment makes weight loss, exercise, and diet. These three are very important measures in control of for the treatment of this hypertension, and of course the resistant hypertension again. Um, Weight loss alone, like 4.5 kgs weight reduction in weight, leads to reduction in systolic and diastolic blood pressure by at least 2 to 3 milligrams. So know how important it is, just not for the cosmetic view, but yes, for your health also, this is very important. So physical activity and calorie restriction is equally important. The with reduction in your weight, there are studies which have found that there is reduction in the number of medicines, number of classes of medicines to be taken, and the dose of the blood pressure medications are also reduced. Exercise, any kind of physical activity, aerobic activity, it is very important, which reduces blood pressure by at least 7 millimeters of mercury, with or without, irrespective of the weight loss patient has achieved. And then diet, there are three modalities, that is reduction in calorie intake, limitation in the sodium intake, and increased potassium intake. 2013 AHA guidelines have proved that reduction by 1 gram in sodium intake reduction by 1 gram per day reduces blood pressure by 4 millimeters of mercury. Higher potassium, as per guidelines now, salt intake should be reduced to 2.3 grams per day. Then higher potassium diet, which helps in controlling the blood pressure, and then limiting the calorie intakes and sugar blood pressure at least mercury. Then smoking, tobacco, alcohol, these things should be stopped, like not advisable for blood pressure control. Then we come to the pharmacological treatment. There are various medications, various classes of medications, which are which we use for the treating of hypertension. The first line medications are calcium channel blockers, ARBs or ACE inhibitors, and then diuretics, beta blocker, and then comes the second line of treatment. The beta blockers are they are not considered as first line of treatment, but because they have a very limited advantage in stroke prevention, but they have protection in heart failure. But yes, each and every patient, as per patient's need, patient's other associated diseases, associated comorbidities, each patient is to be evaluated and started with the appropriate treatment at maximum tolerated doses. Not necessarily we have to reach to the maximum dose for that particular medicine. It should be individualized as per patient's need and patient's tolerance. And careful monitoring, yes, of course, which is very important. After starting the antihypertensive treatment, patients are to be regularly monitored for blood pressure and other associated conditions, and they are to be treated simultaneously, like OSAs, diabetes, thyroid diseases, if there is coarctation of aorta, adrenal diseases, renal diseases, and of course the obesity, which overall is going to give you the result of for any patient. And of course, the compliance for the medications is very important. You have to convince your patients to to take the medications at appropriate times and as advised. Do not self medicate, and do not self do not stop treatment or increase treatment as per your on your own. Every time your doctor has to be involved in it, in your decision. Then there is called newer non-pharmacological treatment, that is surgical treatment, which is catheter-based renal denervation therapy and carotid baroreceptor activation. These are, of course, not the replacement for drug therapy. Patients will have to tried with non-pharmacological conservative treatment and pharmacological treatment first. If and only if these measures fail to control blood pressure for that patient, and uh, it is like a threat to patient's life, and end organ damage, various complications are noticed, then these things are advisable, not as a replacement to the pharmacological therapy. So the take home message will be early diagnosis is the key. Early diagnosis and appropriate treatment, appropriate classes of drugs at appropriate maximum tolerated doses should be advised. Patient's compliance is must. Your patient should be spoken to in depth and given all the information regarding the side effects, the danger signs, everything about the about the condition. Periodic checkups are needed, blood pressure measurements, physical examination, and appropriate investigations at each visit are mandatory. Thank you.
Thank you, ma'am. Ma'am, let me check any questions in chat box, then I will share to you. Ma'am, one question is from Mr. Nandan. What should be targeted BP level for hypertension as per new guidelines?
See, for general population, like patients with no diabetes or this thing, kidney disease, it should be less than 130 by 80 millimeters of mercury. But for patients with diabetes and kidney problems, like with evidence of various end organ damage, it is still lower. It should be less than 120 by 80 millimeters of mercury.
Okay, ma'am. Just one moment, ma'am. Only one question it was, ma'am. Ma'am, thank you so much for wonderful session. It was very nice session, ma'am. Thank you so much, ma'am.
Yeah, thank you so much, Javed and team.
You're welcome.